Hello and good afternoon, respected chairpersons, my dear faculties and delegates. Hope you are enjoying this event. I thank the organizing team, my dear friend Dr. Shrikant and Dr. Shu Prashant for extending the kind invite. I apologize for not being able to make it physically. I have been entitled to speak on robotic surgery for pelvic organ prolapse. I am Dr. Pinak and I bring greetings from Gem Hospital, Chennai. Pelvic organ prolapse is the descent of one or more pelvic organs, like the bladder, uterus, rectum, or the vaginal vault, from its normal position, resulting in protrusion into or outside the vaginal canal due to weakness of pelvic floor muscle and connective tissue. Prolapse is quite prevalent in women, and they run the lifetime risk of surgery up to 10 to 20%. It is more common in multiparous women, postmenopausal women, and those with chronic increase in intra-abdominal pressure. Prolapse is associated with urinary and bowel dysfunction, sexual dysfunction, and a negative body image and psychosocial well-being. Now, if you look at the various compartments, the pelvis is divided into anterior, middle, and posterior compartment. The components of anterior compartment is bladder, pathology is cystocele and rarely urethrocoele, and the support defect is basically the pivocervical fascia. In the middle or the apical compartments, you have the uterus, cervix, or the vaginal vault. Problems arising may be uterine prolapse, the vaginal vault prolapse seen after hysterectomies, enterocele rarely, and the defect is in the uterosacral ligament and the cardinal ligaments. If you look at the posterior compartment, it is the rectum, and the most common problem we face is rectocele. Occasionally, perineal hernias also can happen, and the defect is in the rectovaginal fascia. If you look at the pelvic muscle, the pelvic floor is supported by the levator ani, the various muscles forming the levator ani along with the coccygeus muscle, and the connective tissue is the endopelvic fascia. So defects may arise or tear may arise in these muscles and ligament, leading to weakness and later on development of prolapse. Pelvic organ prolapse is more common in females because of multiple hiatus in the pelvic floor. Mechanism of prolapse is by weakening or tearing of the fascia or muscle. Stretching or rupture is encountered during childbirth or following neuromuscular injuries. POPQ classification is perhaps the most commonly used bedside classification. It is very simple, with 0 being no prolapse, 1 is inside or occult, 2 is at the introitus, 3 protrudes out, and 4 it is completely prolapsed outside. The multiple organs, which we already discussed, could be the bladder, rectum, small bowel, urethra, uterus, or the vaginal vault. Investigations which we do in pelvic organ prolapse are multiple and depends on the compartment used. The one single most important investigation which is done is dynamic pelvic MRI, as it is a single comprehensive tool to evaluate all the compartment in the same session. Rectopexy is still the gold standard for assessment of rectocele or intrarectal intussusceptions. Surgery for pelvic organ prolapse. Previously, it was open surgery, abdominal operations were the gold standards, but nowadays everything is minimally invasive. And when we are working in the small space, robotic surgery is gaining momentum in this area. The advantages of robotics in pelvic organ, we all know that robotics, because of the multiple degree of freedom, better ability to work in tight spaces like the pelvis, a 3D immersive view deep inside the pelvis, the improved manual dexterity and elimination of tremor. These all things allow us to work very nicely in this narrow confined space, reducing the learning curve and leads to lesser exhaustion of the surgeon. And that is why probably robotic is preferred in these scenarios. And also in obese patients or in patients where you expect a lot of adhesions or recurrent pelvic organ prolapse where you need a lot of skills, basically. So I'll be showcasing some cases. The case one is a 61-year-old female on and off pain abdomen with dyspepsia, known case of gallstone disease, history of prolonged difficulty in passing motion, and is mass bulging per vagina during motion. She needs to splint the vaginal wall to aid in passage of stool, and there is no urinary complaint. On examination, one can see that there is a large anterior rectocele. Colonoscopy was normal. MR defibrillography showed significant anterior rectocele and a descent in the middle and the anterior compartment as well during strain. Now, biofeedback therapy is a very important thing, and I think all these kind of weak pelvic floor patients should be subjected to biofeedback therapy for at least 2 months, so that they can improve the strength of the pelvic floor, so that once you repair, your repair lasts for a longer time. Because if we repair in a hurry and we don't strengthen the pelvic floor, we are bound to fail in long run. So we prepared these patients for 2 months, and then we planned for a robotic ventral mesh rectopexy with a cholecystectomy. This is the MRI radiography, and you can see that there is descent of the pelvic organs. This is the pivococcygeal line, and the line drawn from lower end of the pelvis to the anorectal junction is the H line, and from the center of pivococcygeal line to the H line is the M line. In this case, you can see there is significant elongation of the H line and the M line, signifying significant pelvic organ descent. This patient is a port positions for the robo. The uterus is lifted up with sutures. You can see a lot of fibroid there, but as they were asymptomatic, it was not intervened. The bowel is pulled aside. This is the marking of the G-shaped incision, which is made on the pelvic peritoneum. The rectum is lifted up from the sacral promontory. Lateral dissection is continued, and we move towards the deep cul-de-sac. So you can see the rectum is separated, and the rectovaginal septum is incised. So here you can see the rectum and the vagina. So the rectovaginal septum is incised so that we expose the entire length of the anterior rectal wall. So the dissection continues deep down as much as possible, almost up to the pelvic floor, up to the level of the perineal body. So you can use a vaginal speculum, to retract the vagina anteriorly. This is the area of the rectocele. So it's very important that it is dissected deep down so that the entire anterior rectal wall is exposed. So dissection almost goes 10 centimeter deep down. So you can see the speculum coming in. Now we have placed a 15 centimeter by 3.5 centimeter polypropylene mesh. Recently, we have started using physics mesh instead of non-absorbable meshes. This is fixed multiply on the ventral side, and suturing with a robotic is much easier. Finally, the strip of mesh is fixed to the sacral anterior longitudinal ligament over the sacral promontory. This fixation is very important because this is the fixation which is going to keep the mesh and the rectum in place. Further fixation is made on the ventral surface. Around 5 or 6 sutures are taken. And finally, the mesh is covered by closing the pelvic peritoneum. So extraperitonealization of the mesh is done. This completes the surgery. Postoperatively, patient was fine, and she was started on liquid diet by evening itself and was discharged on post-op day 1. Now, case 2 is a post-hysterectomy 67-year-old female. The MRI shows a valve prolapse with a rectocele. She was on biofeedback therapy for almost 6 months, but continued to have persistent symptoms and needed digital evacuation of stool. So the plan was ventral mesh rectopexy with sacrocolpopexy. So this is the clinical examination, and you can see that on straining, and uh, the rectum was popping out of the vagina. So she underwent hysterectomy, so we expected some adhesions of small bowel and momentum was stuck in the pelvis. So adhesiolysis was done and those were taken out of the pelvis. Here we can identify the bladder. So if I use ICG inside the ureter, which is helpful in this kind of operated pelvis. This is a swab inside the vaginal vault. So we have done a little bit of dissection to separate the bladder from the vaginal vault. The bladder is held up so that we have a clear margin to dissect the vaginal vault both anteriorly and posteriorly. Posteriorly, the rectovaginal septum is incised and dissection continues deep down. The difference between rectal cancer surgery and a prolapse surgery is that in rectal cancer surgery, the fat belongs to the rectum. But in prolapse surgery, since you want to fix the mesh onto the rectal muscle wall, the rectal anterior rectal muscle wall is bare. Now you can see we are exposing the sacral promontory. So first, a strip of mesh, again, a 15 by 3 centimeter strip of mesh is fixed onto the. So this is basically actually fixation of the anterior ventral surface of the rectum. So first of all, the rectocele is fixed, and it is fixed with the anterior longitudinal ligament over the sacral promontory. Finally, we move our attention to the sacrocolpopexy. So this is the vault of the vagina. Again, a strip of mesh is fixed to the vault of the vagina, both anterior vaginal wall and posterior vaginal wall. And the top of top of the vaginal uh, vault. So after that, this strip of mesh is also fixed to the sacral promontory. And finally, the peritoneum is approximated, so the it is extraperitoneal. We can see the patient is asked to strain in the postoperative period, and then the entire rectocele is obliterated. So the take-home points are: don't jump onto surgery straight away. A thorough evaluation of the patient's symptoms is very important. Proper assessment with a dynamic MRI is the gold standard. A team approach with urology and gynecology for a multidisciplinary approach is always good. Biofeedback therapy is very useful and essential preoperatively as well as postoperatively. And because we have to work in a narrow area, robotic really shines in this case. I'll end my talk with small quote of mine. Surgery was, is, and will continue to remain exciting forever. Thank you.